Welcome. My name is Corey Richardson, and I am the CEO and Clinical Director of Integrated Care of Greater Hickory. And this is a brief presentation today about substance use disorder and homeless shelters. And this is most appropriate for those persons who are dealing with the homeless and specifically working with this population in homeless shelters, trying to find housing and facing some challenges. And we're going to look at some of those challenges together. See if we can help this population in need and get them the help that they need to turn their lives around. So there is a real connection between homelessness and addiction. And in 2017, there were approximately about 500,000 people homeless in the United States. And the homeless population is increasing yearly. And this is happening particularly in younger and younger ages. And so some people that are working in shelters are probably starting to see this themselves. And then you see that mental illness and co-occurring substance use disorder is probably very prevalent in this population. The end result of homelessness is often substance use, where difficult conditions of living on the street, such as having to find food or struggling with ill health or being constantly away from loved ones, creates a highly stressful state of being, which makes using an early mechanism to cope. And so in this situation, you'll see not only is substance use driving people into the streets, but sometimes if you find yourself because of poverty or other situations, you'll start to use drugs and alcohol as a coping mechanism, and this is very common in the population. So individuals suffering from homelessness may additionally develop psychiatric conditions in response to the harsh lifestyle of feeling threatened by violence, starvation, lack of shelter, and a loss of meaningful relationships. And so you start to see some really challenging situations with people when they're coming to you, psychiatric, and this may be severe psychiatric, intrinsic stuff such as schizophrenia, bipolar type 1, and it may be subsequent to physical trauma or environmental stressors. So that might be something that has occurred as subsequent to their homelessness. Reports suggest about a third of homeless people battle with mental illness, and sources cite mental illness as another major cause of homelessness, which often leads to drug and alcohol use. Common mental disorders that homeless struggle with include bipolar, paranoia and delusions, schizophrenia or schizoaffective disorder, PTSD, particularly in our homeless veterans, major depressive disorder, and anxiety. And so trying to place these people and keep them in housing or keep them in shelters, it can be a challenge because of the lack of stability and the need for appropriate levels of care, which could be very hard with people who have no insurance. And substance use has shown to contribute to homelessness. And this is something that we're very familiar with. The National Coalition for the Homeless has found that about almost 40% of people are alcohol dependent that live on the street, and about 26% are dependent on other harmful substances. And now these numbers may seem rather low. They are significant, and I think that periodically these numbers seem to change. But for me, they seem a little low. But this is some recent data that I was able to pull. So one of the first things that we look at, and I think that people that work in the shelters have a real understanding of, is addiction is not a choice. Substance use disorder is not a consequence of a moral failing. It is a true brain disease. Now, this talk today is not specifically about the brain disease, but as you know, certain people, either initially or over the course of use, their brains really do become hijacked, and they're making so many decisions that are driven by drug use and not by a full functioning brain. And we never look at somebody's schizophrenia and say that they're a bad person, or how can they be making these really silly choices, choosing homelessness when they have so many other options, and they're choosing drugs that puts them in situations that are dangerous. But we never say that about schizophrenia, but we always find people in our community talking about the addict in this way. And so one of the first things that we have to look at as providers, either providers of healthcare services or providers of housing for this population, is really our outreach to the general community and really changing hearts and minds about addiction as being a brain disease, very similar to the other psychiatric disorders we've just spoken about. So how do you recognize the use of drugs? And we're going to look at some signs and symptoms. So if you're working in a shelter and you've never used these drugs yourself, you start to see some of these things. And so while many people who are listening to this have a good understanding, whether it's law enforcement or people that work in the shelters or volunteers, if you're new, you're going to start to see some of these things. And so heroin and pain pills, those powerful opiates and opioids, do cause drowsiness, mental confusion. If you look at their eyes, they have pinpoint pupils. You may see needle marks. So sometimes we'll see people wearing long sleeves in the wintertime to try to hide that. Nausea, constipation, and depending on the dosage, you may have slowed or even stopped breathing. So other consequences may include lack of interest in any kind of activity and decreased attention to personal hygiene. Items frequently used may include aluminum foil for smoking or straws for inhaling. So you might see some of this around the bed area or in the trash bins. And prior to injecting, users may dissolve it by burning it in a spoon or something similar. And you may see these needle syringes and maybe use Band-Aids. Now, some people will have a paradoxical effect, while some will have a slowed kind of a feeling or response time for opiates. Some people get a lot of burst of energy, but always at very high levels of opiates and opioids, such as heroin and oxycodone. You're going to definitely see at the higher level dosage that slowed speech and slow breathing and risk of death due to overdose. If they don't have the drugs that they're usually taking, everyone knows about withdrawal. And this will be muscle aches, nausea, fatigue, runny nose, sleeplessness, severe. And so this should make staff alert that these people are in withdrawal and they may go back out and use, or they may try to find something while they're staying with you, which could be a very catastrophic situation leading to overdose. Here's a nice little picture, just kind of that you might look at if you have somebody coming into your shelter with constricted pupils. You might see a needle mark somewhere. They may have some unusual scratching at the nose and face at higher levels. And this is kind of very pathognomonic of drug use, heroin and pain pill use. There may be some nodding off right there in front of you, sleeping. You can't seem to get them to concentrate or stay awake. And we talked about covering your arms, even in warm times, to kind of hide those marks. And poor coordination. So you got some of these kind of real easy to see physical signs and some symptoms. There are some harder to detect physical findings would be those pupillary constriction, because a lot of your population may have a hat or glasses that have a little bit of a tint to it. They don't want to look you in the eye. The lower blood pressure, the slowed heart rate is very hard to detect without doing the vital signs, having somebody measure those. An overdose can lead to that respiratory depression, extreme lethargy, and it progresses to low oxygen levels, higher carbon dioxide levels, and they can slip into a coma. They can stop breathing altogether. They can aspirate into their lungs. And many of the people that have active addiction, especially those who use straws and needles, may have hepatitis C, endocarditis, chronic constipation, and liver or kidney disease. So there are some signs and symptoms underneath that, and we'll talk a little bit about how we might be able to fully assess one of your residents, either at your own site or with a provider like Integrated Care. So how do you recognize the use of drugs, signs and symptoms when it comes to the sedatives or the tranquilizers? Well, you will definitely see drowsiness, dizziness, and confusion with problems with movement and memory. They might have a slow heart rate and breathing, which may worsen when combined with alcohol or other drugs like methadone. There is an increased risk of falls and injuries. So you may see some of this on their person. How did you knock your head? How'd you cut your eyelid? Did somebody hurt you? No, I fell. And so sometimes they may be protecting a significant other or intimate partner when they try to talk about some of the injury, but they may just be falling frequently because of high levels of sedatives or other drugs. Worsening depression and anxiety are usually symptoms with worsening use of these drugs. Impaired attention and judgment, mood swings, and inappropriate behavior. Now, while a lot of people think of sedatives as putting you to sleep, there is a paradoxical effect with a lot of drug users where they get very agitated and they get very angry and they even become combative, even with law enforcement. And many people who use these drugs will talk about that on Xanax and other powerful benzodiazepines. And the withdrawal, just like with our opiates, is kind of the withdrawal is always the opposite effect. So if you have a lot of sedation while there's active use and heavy use, the withdrawal is going to be kind of the opposite of that. So you might have, and this might be life-threatening, like seizures, muscular and neurologic seizures. They get extremely stimulated and agitated and unable to sleep. And so there's going to be some of that too. But when it comes to taking people off of benzodiazepines, it has to be done in a controlled environment. It can't be done abruptly because it can result in loss of life. How to recognize the use of drugs when it comes to alcohol. So, and most of us understand this to a large degree. We may smell it on their breath. Sometimes there's some ways of kind of hiding that. Or using, if there's no alcohol available, they may be using mouthwash or isopropyl cleaning alcohol or even cleaning solutions. Hand sanitizer has been, people have seen many people drink hand sanitizer in certain controlled environments so they can get the feeling of the alcohol. So you'll have poor coordination, slurred speech, smell on the breath, impaired thinking, worsening memory. They want to stop drinking, but they're not able to do so. And so there may be some secretiveness about that. Engaging in risky behavior such as drunk driving, inappropriate sexual relations. Maybe you may see somebody coming into your facility, crossing a road a little too recklessly. And so there's some of that kind of risky behavior. And a lot of times they'll be really in denial of alcohol or making up other excuses like, well, I need to stay warm and other situations like that. It's not really a problem for them. Many times that when people are in housing and they do not have access to alcohol, there would be a lot of frustration and distress about the limits of being able to get a hold of alcohol while living in your residential program. So when a person who regularly abuses alcohol stops drinking, kind of like with our benzodiazepines, you might have some real serious withdrawal symptoms that can be life-threatening. So some of these symptoms may be as soon as 2 hours after last drink, and they may continue for weeks. So these are shaking and anxiety and the desire for the drink, and the most serious is going to be our DTs. Delirium tremens are severe withdrawal symptoms that lead to confusion, fever, rapid heartbeat, and people can die from that. If you've ever seen anybody go into DTs, it's almost like they're psychotic. They're seeing things, hearing things, and it's a very serious situation and they need medical attention, similar to the benzodiazepine withdrawal. There's a general advisement with alcohol withdrawal should be under the care of a doctor at a specialized addictions treatment center or hospital, and that way these can be managed appropriately. And we're going to talk about stimulants. In Hickory, North Carolina, and our surrounding counties, such as in Lincolnton and Gaston County, we now see some seriousness with methamphetamine, powerful stimulants. So these changes usually decrease appetite. You'll see twitches and jitteriness, so a lot of movement of the hands and nervousness, rapid heartbeat. This time, unlike with heroin or opiates, you'll have a dilated pupil and kind of a crazy looking eye. It's going to be a huge dilated pupil. It's that fight or flight that's going on inside their head, and the muscles of the iris are really working hard to open that pupil up. There'll be elevated blood pressure. You'll start to see some real weight loss, hair loss, skin changes, A lot of times people know that kind of pathognomonic picking at their face, and so you have some really serious skin problems, including some skin infections, needle marks, and a lot of sweating. And also a lot of confusion of thought, paranoia. So this kind of hyper focus, a flight of ideas is going on, sensory awareness. Somebody drops a book, they may really jump, racing thoughts and confusion, paranoia, they may start to see things. So these may be auditory, hear things, visual. Somebody's out to get me, somebody's outside my window, I see them right now. A lot of delusions about who they are, what's going on in their life, and a lot of poor judgment and decision making. So staff may observe this anxiety and depression and the mood swings, anger and aggressiveness. Then they may have some really increased confidence, and then maybe suicidal. So you have some of this going on. Some of the accoutrement that you might see would be like pipes. You may see cans that bent over to use to smoke the stimulants, either crack cocaine or methamphetamine. Aluminum foil can also be used, or a light bulb. You can remove the metal part of the light bulb, and the drug can be dropped into a cleaned out light bulb and smoked. Straws for snorting, needles for injecting, and of course, they can also be taken orally. Stimulant withdrawal is the opposite of the drug's natural effects, and that would be fatigue, real slow movement, agitation, unpleasant dreams, inability to sleep, or they may sleep excessively, and all of a sudden they have their appetite back. One quick comment about stimulant overdose. We know that benzos, methadone, opiates, and even alcohol causes death. We are starting to see some real powerful stimulants now causing overdose death as well. So is this person safe to stay here tonight? So the staff and the intake staff is going to have to start making some serious considerations. And we like to break them down into maybe 4 categories. The person is intoxicated, but they seem to be safe to remain in the housing. You can tell that they've done something, but they're communicating well, they're not acting inappropriately, they're relatively stable, and they don't seem to be getting any worse in front of you. Now, you don't know if they've taken a lot of drug and the level of intoxication is going up, or the level of intoxication is going down. But they do appear to be answering questions. They are aware and oriented to what's going on. They know who they are. They know where they are. And you can do a quick mental status and kind of figure out where they are. But you know that this person is probably intoxicated. So this person may be one of these that you could put in a place that's a little bit more readily available for observation with staff throughout the night. So there may be somebody intoxicated that's not appropriate for housing, but needs no medical evaluation. So this person is a little bit agitated, they're a little bit angry, but you don't see any real challenges when it comes to their breathing. You don't see any challenges when it comes to their speech, as in slurred speech, unable to walk, slowed breathing, some of those real serious symptoms that you would look for, signs that you would look for. This says, this person physically is not well. And a lot of us can tell what's not well. And you might want to, we'll talk about maybe the idea of doing some vitals or some brief evaluation of breathing and pulse and respiration and blood pressure within the residence, or having somebody be available to maybe do a brief medical or physical exam in concert with the staff. But this person would probably not be appropriate for housing. They're agitated and angry, and they're looking for a fight. They're looking to cause some problems. They're clearly intoxicated, but they don't appear like they're going to go into overdose when they're looking at you. But they don't need medical evaluation. Now, some people you're going to see are going to be very intoxicated, and they're going to have slurred speech, slowed breathing. They're going to be falling and stumbling. They can't seem to even get up and move around easily when they try to go to the bathroom on their own or get through the door. This person may need an evaluation at a hospital. They may not be a danger to themselves or others, but they may be falling into overdose, and sending them back out in the street may be the end for them. And so this person may need to be sent to the ER through an ambulance. So there are situations where the residents would call EMS and the EMS would take over responsibility, even if the person refused or had the ability to refuse. And that would fall into the next category. So they may be intoxicated and they may be a danger to themselves or others. So they may be so intoxicated and trying to refuse medical care, and the staff, the EMS, paramedic, and ambulance workers understands that they're going to have to take them in forcibly, or they're going to call for backup from the police, or this person may overdose and die. Narcan, one Narcan may revive them, and now they're trying to refuse going to the hospital. And everyone knows that Narcan given by the ambulance or by a staff member at the shelter is not going to last. They may be so intoxicated, not going to overdose, but they're trying to harm other people, and they may have a knife or other type of weapon. And so you got 4 instances here of different types of person that are intoxicated coming into your housing, but you might consider involuntary commitment. And that would be in concert with maybe the ambulance, the paramedics, EMS services, the hospital staff. And this evaluation will probably be done with this person at the hospital. So the shelter interview or the intake. This can be a very important part of determining not just if the person can stay or not, where they are in their life today. Is this a new event, or is homelessness chronic? Even though you might not have met them, they may be coming from another environment. And if they have a drug or alcohol or psychiatric disorder, maybe we could talk about a referral to the appropriate source. So there may be some higher levels of a concern. And in situations in residence, very often there may be some screening tools at intake that take maybe 30 seconds or less that you could help kind of guide you on determining if they have an alcohol or drug problem. Placement in the facility for somebody who is intoxicated may be closer for observation. So if the level of intoxication is going up and they're getting worse, or they use and they're coming off of it, you'd be able to follow that pretty closely. You'd also be able to watch for recurrent use. If they had somehow were able to sneak something into the facility, you could hopefully try to watch for recurrent use. True random drug testing and bed checks. We have a situation in our office where we try to do true randoms, which means if you can pull from a true random system, whether it's a hat with numbers or it's a computer program, rather than when this person comes in, she usually starts here, or this staff person usually does drug testing and bed checks in this area. Patients seem to intuitively figure out when some of my staff do some of their randoms, because it's not random anymore, but the staff member thinks it is. Is there rescue Narcan, what we call naloxone or rescue Narcan, in the facility? If somebody is intoxicated, or we don't know that they have just used, they don't appear to be overly intoxicated on intake, but now they're falling into overdose, it's very important to be able to shoot them with some rescue Narcan and then call 911, because it doesn't last very long. If they don't revive immediately with that first injection, another injection immediately. If you're unsure if it's an opiate, it's fine. You can still give them the rescue Narcan. And most people in the residential communities, the staff of residential housing, like shelters, have had some training and are able to use Narcan. And also embedding inside of shelters like Salvation Army and other halfway houses, really embedding peer support, recovery coaches, or staff that have lived experience with drugs and alcohol use, addiction, psychiatric problems, mental illness, and even trauma. And so that kind of lived experience, that either peer support or really somebody that has some training, like a recovery coach, to really talk to people about these sensitive issues, open up some kind of conversation, increase motivation to maybe seek treatment, and know what those treatment referral sources are. So communication skills used by staff, motivational interviewing to discuss those treatment options with those who are initially very resistant or ambivalent to the idea of recovery or even an abstinence. A lot of times when people are struggling with substance use disorder and or mental illness, they don't want to talk to you about it, and they're fine. And so this kind of really open-ended questions, respectful dialogue, a lot of active listening, and other motivational interviewing techniques can really start a conversation to determine, maybe it won't fail this time. Maybe treatment will be better this time. Maybe you don't have to live this way, or maybe you just want to talk to somebody about what you're going through. 12-step meetings and other recovery support groups, not only out in the community, but also within the shelter, working with people who are in recovery and these kind of group settings could be very helpful and important to demonstrate that, give it hope that if these people can get clean and sober, maybe and even overcome a lot of mental illness through medication if appropriate, so can some of the residents. That leads us to also considering speaker meetings and guest speakers within the shelter. That because many people who are in recovery were themselves in shelters because of their addiction or mental illness. And so speakers are able to motivate people to seek help. Encourage the community AA and NA participation. And sometimes that's just put your butt in the seat and just be open to the process. And for people who are trying to find something to do during the day, many meetings go on in the morning and the afternoon, and would give them that opportunity to get a cup of coffee, maybe some sweets that are there, and just kind of meet with somebody who also has traveled in their shoes. Quick, easy referrals to treatment day programs that offer transportation as well as food and beverages. So when we start to talk about options, there has to be a tight referral system from the residential staff to the treatment community. And this is really what we're talking about and why we're working with at ICGH, working with our residential communities, our shelters, Salvation Army, etc., to try to reach this population. Our peer support also go to persons that aren't in shelters, but we know they're homeless, either in areas where we know they're tents, where we know they kind of spend time during the day. And so this is another way that we're trying to get referrals from the community, direct referrals from people that are homeless, and get them into our programs. Here are some of those tools that we mentioned earlier that you might consider in a shelter. Audit, a DAS, so these are alcohol or drug specific. We generally in our programs will look at criteria to gauge how severe the disease is, to try to place them in the right level of care. And so this slide here is also for tools that we use for clinicians, doctors, PAs, and NPs, when they're then in a primary care setting to determine if there might be a drug or alcohol problem and a need for a referral. When they come to us and we do our assessments, we do try to find the best level of care. And so for many people, that may be a 3-day-a-week class, 3 hours a day. Many people that are coming out of shelters have a lot of challenges: educational, employment, mental illness. They've been on drugs for a long period of time at a high level. They may have a lot of these challenges, so they would need partial hospitalization. We would come pick them up, and they would come to our program 5 days a week, and they would stay with us 4 hours a day. We feed them, and we address all those other inputs like education, employment, trauma through our counselors and our therapists. Many people that are in the shelter and do well in our programs, we also find residential housing that's not a shelter. So we at Integrated Care also have transitional housing that we are now, that as part of our program, our ongoing programs. When you refer them to a specific treatment provider, and this is self-evident but not always done, we need to have a treatment model that includes the biopsychosocial. There are going to be the persons that are in the shelter have had negative effects of from their disease of addiction and or mental illness, and it's affected every aspect of their life: housing, their ability to work, their ability for transportation between appointments, food, shelter. Like I said, they have had a lot of trauma, and they may have some co-occurring disorders that are psychological related to bipolar, psychiatric, and then medical conditions. A lot of people who end up in shelters because of drugs and alcohol are going to have poorly controlled medical conditions, be it hypertension, diabetes, cholesterol. And so when we do our assessments and we create a treatment plan, we have to include all of these considerations that they need and make sure that all the problems have interventions that meet those needs. And the principles and the features of such a model would be stigma-free, strength-based, person-centered, peer-supported, outcome-based. When you work with providers like an integrated care who are in recovery, and be they the counselors, the peer support, the therapist, all of the providers that work on our team have to have a non-judgmental, open approach to working with this population. And we all, and the good thing about a treatment model like this, you don't send them here, one person for the medication, another person for the counseling, another place for education or employment training. We were able to house all this under one roof. And then we're also able to work very tightly with our referrals for coordination of care for very specific needs that go outside of what we offer at integrated care. We offer a recovery-oriented model that's based on a 12-step facilitation. We do offer medication for substance use disorder, like opiate use disorder, for like Suboxone, and that is free of charge for anybody uninsured, just like all of our programs are free for the uninsured when it comes to the opiate use disorder. We address the mental illness and trauma as well, and we are able to provide medications when appropriate for those persons, and these medications are always non-addictive. When treatment ends, we don't want people to have recurrent use or fall back into severe mental illness. We want them to be able to continue their medical management. And so we do surround them with support in the community. And that will be AA, NA, other social supports like peer support, so that once treatment ends, we can sustain recovery and they don't fall back into drug and alcohol use, severe mental illness, and homelessness. So what sets us apart? Well, our programs have small group sizes for counseling, so no one really can hide, and it's that makes it more of a meaningful experience and a higher level of interaction. We have very flexible counseling schedules, and it includes some evening and Saturday appointments. We offer every level of care, which is 5 days a week, 3 days a week, our basic services, which is about 1 to 2 days a week, depending upon the level of care that's needed. And we have very close interactions. We call that a very integrated approach between counselors, our medical providers, our labs, our lab tech, our toxicologist, our pharmacist, AA and NA community. So when we say person-centered, we mean a whole person approach under one roof. We really try to, and we have these team treatment meetings so we can all be at the same table at the same time talking about the same goals for our patients. We offer free transportation. We have free housing in some of our programs and free medication to the uninsured when it comes to the opiate use disorder problem. Most of our counselors are in recovery themselves, or they have very tight familiar experience and apply the steps in their own lives because addiction or other process addiction problems than the substance use disorder. We hold a lot of fidelity to the 12-step model, and there is mandatory participation for all of our patients in the recovery community. And as I said earlier, that's so that when treatment ends, people don't go back and use, recovery can continue. And so we have a lot of agencies only take state funding or Medicaid. We accept Medicare, Medicaid, private insurances, and we have a lot of state funding for those without any coverage. And if you have somebody in one of your shelters and they're on somebody's insurance, they still can, that insurance can still be used for the intensive outpatient services. So care for all behavioral disorders with appropriate medication management includes Suboxone, as well as non-addictive medications for depression, anxiety, trauma, ADHD. So we don't just treat the addictive process, we treat the whole person. We have licensed providers. We have walk-in services for those assessments. We have on-call coverage 24 hours a day for our persons in our program. And we address substance use disorders along with other behavioral health problems. And on initial intake, we detect all medical disorders by using family care providers, whether they're physicians or PAs. And that way we can do our tight referrals to whether an HIV clinic, hepatitis clinic, free clinics in the community. Not just a psychiatrist that sees that somebody has a substance use disorder and just gives them Suboxone. We do full physical exams and workups. So in conclusion, partnering with shelters and transitional housing, we want to say that we do focus on a person-centered concept, which includes housing and specifically those persons that staff shelters and transitional housing that's not our own. And we definitely don't adhere to a rigid service-focused program that really neglects the participation in the recovery community. Our counseling, medical, nursing, and administrative staff have personal experiences in recovery or close contact with the disease and apply the steps in their own lives to better deliver this service, this treatment model. And it's that experiential knowledge of that lived experience that everyone knows about, that lived experience that ties us to the recovery-oriented community. We are equipped to serve the uninsured as well as those that have insurance. And we have a staff that is not only diversely trained, very diverse staff. We have on-site testing for drugs, and we have an on-site pharmacy that allows us to provide close monitoring of medication so it's not diverted out in the community or sold. And it also allows us to give free medication for those that are uninsured when it comes to the opiate use problem. This is a lot of what we do in our community, and I think a lot of people in Hickory, Gaston, and Lincoln counties know us. So in Catawba, Gaston, and Lincoln counties, they see us a lot with our 3 sites, and that means working with our legislators, our governor, means a lot of outreach opportunities, a lot of service work in the community, as well as teaching at Wake Forest School of Medicine. More of what we do, including our research in the healthcare field that is now recognized internationally, our community coalition work with Project Lazarus and our new program in prevention, working with our church leaders, educating them, and of course getting the medication to those who need it most, who are uninsured, so that they can actually stay in treatment without going right back out into the community and using. Here's some of our contact information. I'll have a lot of this information available to you after the webinar is over, and this information is available to staff, and we want you to be able to leave it out so that some of the residents will be able to pick it up and use it. I want to thank everybody for taking the time to watch this webinar with us today. And if you have any further questions, please feel free to call me or any of my staff. Hopefully we can partner with you and get the needs of your residents met when it comes to addiction, mental illness, and any of those challenges. We're really ready to work with you on meeting their needs. So thank you.